We will continue with Dr. Falara. Since 2021, Dr. Falara has successfully completed the fellowship program, and she is the asset of our department. Please, Dr. Falara, you can start.
Okay, thank you. Good evening, everyone. Thank you very much for the opportunity to participate in this meeting. I'm going to make an introduction for pulmonary hypertension, referring to its definition, its classification, and evaluation of patients before cardiac surgery. As we all know, the pathophysiology of pulmonary hypertension is complex and multifactorial, resulting in progressive changes in pulmonary vasculature, such as vasoconstriction, vascular smooth muscle cell hypertrophy, intimal thickening, and in situ thrombosis. And the end result of all this is a reduction in the cross-sectional area of the pulmonary vasculature, leading to increased pulmonary vascular resistance and increased increased left ventricular afterload. Now, although pulmonary hypertension has been defined as an elevation in mean pulmonary artery pressure above 25 millimeters of mercury over the passing years, the 6th World Symposium for Pulmonary Hypertension in 2018 updated this definition, and it defined it as an elevation of mean pulmonary artery pressure above 20 millimeters of mercury. But whatever the mean pulmonary artery pressure cutoff value is considered for defining pulmonary hypertension, it is important to say that this value used in isolation cannot characterize a clinical condition or define a pathological process, because as we know, and as you can see, pulmonary artery pressure elevation may have several different causes. So currently, when we refer to pulmonary hypertension, we should also take into account pulmonary vascular resistance and pulmonary artery wedge pressure in order to categorize pulmonary hypertension in precapillary form, characterized by normal wedge pressure and increased pulmonary vascular resistance, and to post-capillary form characterized by normal pulmonary vascular resistance and increased wedge pressure. And of course, these entities may coexist, leading to combined precapillary and post-capillary form. Now, apart from this hemodynamic definition, here comes the updated clinical classification of pulmonary hypertension by the 6th World Symposium into 5 groups. And if we cut it into pieces, we have group 1, pulmonary arterial hypertension. This group was updated by the 6th World Symposium in order to include new drugs and toxins associated with pulmonary arterial hypertension, such as amphetamines and methamphetamines and some other drugs. And they also added 2 more distinct groups. First of all, they added a group of patients with who are defined as long-term responders to calcium channel blockers, because they showed because these patients were found to have improved survival when treated with long-term calcium channel blockers. And they have also added a group of patients with overt features of venous capillary involvement, because these patients seem to have poor prognosis and decreased the response to pulmonary arterial hypertension treatment. Then we have group 2, pulmonary hypertension due to left heart disease. Group 3, PH due to lung disease. Group 4, PH due to pulmonary artery obstructions. These 3 groups have remained unchanged, and there was also an update in group 5, in the name of group 5. And according to its current definition, it includes forms of pulmonary hypertension with unclear or multifactorial mechanisms. Thank you very much.